Hello, good morning, everyone. We have a very interesting session this morning. This is part of our project called Unpause, Caregivers, the Heroes Among Us. And this project is actually organized by Breast Cancer Welfare Association with support from Pfizer Malaysia. And this is the third of the series of sessions of webinars that we've had since the October month. And also we've had several events and activities where we had caregivers and patients sharing the issue of caregivers and the heroes among us. So sometimes caregivers can be family members, they can be someone who looks after you. Sometimes I even say a caregiver is a healthcare professional. So coming to that, the topic is facilitating difficult conversations with conversations with patient and family. And I think I would keep the family as part and parcel of others who are around the patient as well. So we have Dr. Sylvia McCarthy, who is a medical director of Hospice Malaysia. I've known
Hello.
Dr. Sylvia for many, many years. Dr. Sylvia, welcome to the session.
Thank you, Ranjit. Thank you.
And Dr. Sylvia McCarthy has been in palliative care work for years and years and years, and she has plenty of grassroots experience with patients and families. And today we're going to have a very enriching session with her. And besides her, we have another guest speaker who is Crystal Ng, and many of you may know Crystal either personally or through the media as well. Crystal has been a long-time friend of mine, as she's also a metastatic breast cancer patient. Welcome, Crystal.
Hello. Hello, everyone.
And Crystal has actually been one of the founding members of Candy Girls, which is a dance group from UMMC. She's also a strong advocate, patient advocate for advanced breast cancer, particularly. And Crystal is at the same time also on the committee of Together Against Cancer, which is an advocacy body in Malaysia, looking at making the needs of patients more available. So in this particular session will be Dr. Sylvia will actually talk about decision-making conversations with a loved one who is facing metastatic breast cancer or challenges on end of life, or even different aspects of treatment, care, and distressing touch points, which are not sometimes easy to have, particularly when it is with people around you. And during this, our final session of facilitating difficult conversations, we will cover the different areas, particularly regarding communication and between patients. Sometimes, I think, Dr. Sylvia, you might also be touching on friends, and I think, even Crystal will be touching on friends, issues of friends, because they become part of that inner circle as you go along in life. So I would like to now invite Dr. Sylvia McCarthy, who would actually speak about this issue of difficult conversations. After that, we will have a session of discussion between the three of us, and then we will take up your questions as well. So over to you, Dr. Sylvia McCarthy.
Thank you very much, Ranjit, and thank you for that very kind invitation. I'm very excited to be talking to everyone today. Ranjit asked me to talk about facilitating difficult conversations with families and loved ones. And I've put together a few slides. I'm very aware that you're all from slightly different backgrounds, and probably some of you are family, some of you are friends of someone who's going through breast cancer, and some of you are patients or probably don't want to be labeled as patients. But you all have your own expertise. So I really hope that you put questions in the chat box. And if I don't address things that you'd like to talk about, please do let me know. So I always find this image really helpful. The elephant in the room. I'm sure many of you are very familiar with this. The idea that when you're unwell, it often feels as if the conversations you're having are not real because no one's really talking about what's going on. And the same is true for family members, that there is something that they would really like to talk about, but they feel the need to avoid. Often for fear of upsetting each other, we stop talking or stop talking openly. And one of the things I'm going to come on and talk about families as systems. And this is sort of an introduction to that. I'm sure many of you, again, have seen this. It's the idea that we all look at the elephant or the problem or the situation from a different perspective, and we see it in different ways. And the importance really of recognizing that we all have a perspective and it's all valid from wherever we're coming from, and that everybody is really working in the best intentions, but sometimes unintentionally causing hurt. And of course, this is one of my favorites. How do we see ourselves, and how do others see us? Is sometimes a big difference. And just before we started, Crystal said something to me that I thought was really important. She talked about when you have recurrence of disease, you think because you've been through it before, it should get easier. And sometimes the people around us think, oh, well, this person knows how to deal with it because they've been there, you know, they've had all the scans, the investigations, the treatment, they know what's going to happen. But it's not easier. In fact, it's sometimes almost more difficult to put yourself through these things again. And sometimes that isn't quite appreciated by those around us. So I wanted to introduce this theory because I think it really helps us to have a more holistic view of what's going on. When I talk about family systems approach, I'll use the term family very loosely. It's the people around the patient who matter, who form part of the support network. And we can think of that group as a system, people who interact with each other. And at the same time, all of these people interact with other systems. So you can think about hierarchies and subsystems and boundaries. So for instance, a family system is part of a larger set of systems like the healthcare system, and how the family interacts with the healthcare system. And within the family, within that grouping, everybody has their own subsystems. So the person with breast cancer might be have a nuclear family, but maybe brothers, sisters have their own family, their own in-laws with whom they also interact. And if they have children, those children might be married and have further families, subsystems as well. So it's understanding that we all work within one system where we come together, but other systems as well. And that when we're thinking, and this is coming on to what holism is about, is that when we're thinking about the problems facing one person, it's not just one person, it's everybody within that system who's affected. And so when we think about how we're going to address the problems, we need to think about everybody who's involved in that system. So one change for one family member affects everybody. And most systems work towards stability. If there's change, people adapt and people manage that change and they come together to support each other. But it can be very challenging. And I think that's where conversations become difficult, is when the family is kind of disrupted and hasn't found that stability, or that homeostasis is challenged. And I hope that's a helpful way of thinking, you might think about the systems you yourself are part of and how what happens to you impacts on everybody else. And then sometimes how we need to, rather than look at the individual, look at the problem that is facing the system and look at all aspects of that system and see where change needs to happen in order to sort out the problem. That's a lot of theory and maybe a little bit too wordy, but I think it kind of sets the scene also for how we need to communicate with each other. I was hoping to ask you what your difficult conversations are. So I've done some guesswork here, and please let me know if this is not working. But telling someone you have cancer, I think that's always difficult, whether it's a new diagnosis or a diagnosis of recurrence. Most of us care very much about the people around us and we don't want to upset them. And we're worried about how they're going to react. Sometimes difficult conversations need to happen about the future. Obviously, how do we make treatment decisions? I think talking to children can be difficult. And just to add here, for young children, the evidence suggests that having them involved in the care, in what's going on, is actually helpful to their future well-being. They do better than children who are excluded. But children are often excluded because family members want to protect them. And they think by shielding them, by not letting them be too close, it will be easier for them. But the evidence from looking at how children respond when there's illness in the family and how they cope suggests that if they are involved, it's actually better. There may be difficult conversations about who's doing what. Is someone not carrying their weight? Who's taking responsibility for the care, and so on. And sometimes you just want to share the feelings that you have and what you're going through, and you'd really like to listen, or you'd like that to be there to support someone else. Please do let me know if I've forgotten anything. So then I thought about, when do we have these conversations? So I think it's important not to wait for a crisis. You might have time just to look for opportunities and for cues that somebody is ready to talk. So your loved one might give an indication. They might be looking a bit sad, or they might be looking a bit worried, and you might say, is something on your mind? But if they're not very sure or not very confident that you're there and ready to listen, they might not open up. And you might need to really have formal family conferences where you really sit down and think about what's going to be discussed. And then there are all kinds of things to prepare and to think about. Number one is where are you going to do this? And these days you might even have to do it on Zoom or Teams or Google Hangouts, your favorite platforms. I think comfort and privacy are really important, and that includes food and drinks. Who's in charge? Is there one person in charge? I wouldn't say in charge, but more facilitating. So who's the person who's going to make sure everybody gets a chance to talk and is able to listen to each other as well. And that might be helpful to have someone who's not directly involved. And as healthcare professionals, that's actually something that we do quite often, is to offer that kind of input to lead a family conference. There needs to be clarity around what we're going to say, what's going to be discussed, and what's the purpose of the discussion. And even if you're not having a family conference, if it's one-to-one, I think it's really helpful to be very clear about what you're talking about the time frame that you have, and what you hope to achieve from a conversation. Obviously, everyone should have a chance to speak, and everyone should listen, and ideally phones should be off. If anyone wants to record the conversation, they should ask permission from everybody, and it should be very clear who's going to have access to that recording. Because if there's no privacy around what's being said, that will impact on the quality of the conversation. Sometimes people take photographs and put things up on social media without asking each other, and I think that's very hard. I've put here as a reminder to myself circular questions, and that's something we use in family conferences, which I think is sometimes quite helpful. Rather than saying to someone, how do you feel? You say to them, how do you think the other person is feeling? And that can open up the conversation in many different ways. Asking someone, well, how do you think I'm feeling in this situation? And hearing how they perceive what you're going through can be very helpful. I just, again, as a reminder, I've mentioned it before, virtual conversations. I don't know about the rest of you, but I'm not comfortable in virtual spaces. I feel that we miss out on tone, on body language. I struggle because I cannot see whether you're all falling asleep or whether what I'm saying is making any sense, because I work a lot off looking for those cues from facial expressions and so on. So at the same time, I recognize virtual conversations are better than nothing in a time of COVID. COVID, I know, has made life so much more difficult for everyone going through illness. And I'm aware that for many of you, I'm sure that's been a problem, not to be able to be physically in the room with people. So we get very excited about virtual conversations. As we go back to being able to see each other, I hope we don't think, actually, we don't have to get in the room together. Next weekend, I'm going up to Penang for a workshop, and someone said to me, why are you going just for the day? And some of it is being facilitated from KL because not everyone can go, but it's because we think it's so important to get in a room with people. So kind of starting out conversations, this is about thinking about who you're talking to and what we know about them. So really more from the perspective of someone talking to a person with illness, but I think it goes both ways. You may be talking to a carer or family member as well. I'll come on to the dignity question, but I want to sort of stop and think a little bit about the language we use, and this is where your own experience is probably so rich. You've probably developed a language that you're comfortable with, that you like to use around your illness. And where difficulty sometimes arises is when we use different languages. So we talk about the battle or warlike language of cancer sometimes. And for some people, that is a really helpful approach to what they're going through. But for other people, that isn't. And I would caution it, because in a way, then when things go wrong, it's because people didn't fight hard enough. And so then it becomes a very difficult language to use. And I don't think illness and our response to illness is ever, and our response to treatment, it is something that should be made, that people should not feel that they have not fought hard enough. I think we put too much pressure on ourselves. There are so many unknowns about illness, and about cancer, even though treatment is becoming much, it is evolving so rapidly with new treatments. There are still so many unknowns, and there's no right way to go through an illness. Do we talk about illness, or do we talk about disease? Do we need to be positive all the time, or is there space to say, actually, today I'm not feeling great? And can we acknowledge that there are some days when people don't feel great? It's not, and when you're saying that, it doesn't mean you're not being positive. Sometimes, again, we put a lot of pressure on people to be positive, to not say anything negative. There's no evidence that being more negative influences your survival at all. How do we talk about the cancer? Everybody has their own words that they like to use or don't like to use. And again, we need to recognize that and try and talk to each other in the language that we like. So I'm talking a lot, but I've put talk less, listen more. Oh, I missed out the listen, sorry, listen more. And think also about coping styles. There's no right way of coping. The times that we need to worry is if someone seems to be really struggling with life. But if someone is okay, getting on, managing, but not wanting to talk about the future and wanting to live from day to day, that's absolutely okay. If someone is a planner who wants to make plans for the future, that's absolutely okay. We just need to recognize that and support that. At the same time, recognizing that we also have our own coping styles. And sometimes we can just learn from each other's style and try new things out. So it's a lot about respecting how everybody copes. So I want to come back to the dignity question. It's something that's developed by a psycho-oncologist, Professor Harvey Chorchnoff, who's done a lot of work on dignity in cancer care. And he came up with this question, and it's for healthcare professionals, but I do offer it to everyone because I think it's a helpful question. What do I need to know about you as a person to give you the best possible care? The best care possible, yeah. So in English, that sounds like a really difficult and clumsy question, but it does kind of work. And I did some translations with, and I've asked my colleagues, they say these translations are okay and that they work, but I'd be really interested in your response to them. So please let me know if it needs changing. Thank you. But it really just brings us back to getting to know each other as we wish to be known. I also wanted to, and this comes into language again, some of the labels we use, being brave, being strong, giving up or refusing. I spend a lot of time, because we do in Hospice Malaysia, we do quite a lot of teaching. So the palliative care specialist trainees spend 6 months with us, and the family medicine specialists spend a month with us through their training. And I spend a lot of time thinking about language and how that affects how we see people and how we talk about what's happening. Medical professionals are terrible with jargon and terrible with language. And the one I always pick up is refusing. And it comes on to decision making. When they say, oh, the patient refused chemotherapy, I always say, no, they didn't refuse. They made the decision that was right for them. Again, the idea of being in denial or acceptance. I think those are two far ends of a scale. I think there are days when people don't want to think about illness every day, and they want to be completely like anyone else. The risk is that someone will say, oh, they're in denial. And again, this sort of goal of acceptance. I think there are days when we feel comfortable with what's going on. We feel we've got a grip on things, but there are days when it is more difficult. And most people fluctuate. So I don't think these labels help very much to understand it's so much more complex than that. And I'd be interested to hear from you as to the labels that you've been given and how they've helped or not helped you, because sometimes they can help. When we're talking, also, we often ask very factual questions. We ask the questions, sort of, what tests have you been through? What treatment are you doing? Which hospital did you go to? Which doctor did you see? How much does it cost? Rather than more exploring questions of how do you feel? How do you think? What do you like? What do you dislike about a situation? I've deliberately put how do you feel and what do you think? Different people respond to those questions differently. And if we're very attuned, we can hear how someone talks. So if someone says, well, I feel this might be the best option, or I feel I don't want to do things like this, or I'm feeling very bad, then it's the feeling questions that you need to ask. But if someone is talking about, well, I need to think this through, or I think that, then you need to talk about thinking, because it describes how they manage things, if you like. So it's about being attuned. And again, being very clear about what we mean. So these are some of the things that I think are worth exploring. Sometimes I get asked, is it serious? And I really need to understand what the person asking the question means by that. Because it means different things to different people. As a doctor, I might think something's not very serious, but it is very serious in how it impacts on the patient. what does getting better mean? People say to me, I'm hoping to get better. And on the one hand, for some people, that's a hope for cure. And for other people, that's a hope for being able to do a bit more than they were able to do yesterday. So exploring exactly what we mean. And this is really important when it comes to decision making as well. Thinking about what we mean by benefits, by harms, by outcomes. Thinking about what we mean by best care. And sometimes we want not to be too direct because we think that will hurt, and we use gentle words. But there's a risk then of miscommunication and of lack of clarity. So I hope that you meet healthcare professionals that ask you to really think about what you mean with the questions that you're bringing. But I fear in our busy healthcare system that many healthcare professionals don't really have the time to understand your questions well enough. So I would urge you to really think carefully about the questions that are meaningful to you, that are important, and try them out. Try them out with your friends and family so that when you bring them to a consultation, it's very clear about what it is, what answers you're searching for. I probably don't need to remind you about nonverbal communication, tone, posture, presence. And I know that you watch the nonverbal communication of your healthcare professionals as well. And that how we talk to you, how we sit down with you, the time we give, how we look at our phones all the time are so important. So that's a lot of kind of background about communication in general and communication with families. I know decision making is terribly important and terribly difficult at times. So the first thing I'm sure you probably know for yourselves by now, what kind of a decision maker are you? Are you someone who wants to make the decisions on your own? You want to gather all the information, go through it, and just decide. Are you someone who wants to make them with someone else, or do you want to leave it to another person? And what's the information that you need? I'm afraid as healthcare professionals, what we're very good at is giving you medical information. But through working with patients, I understand that there are so many more factors that come into the decisions you make. How is it going to impact on your life? Not just on you, but everybody around you. What is the outcomes that you can hope for? And for patients receiving oncology treatment, many of them are often thinking that the treatment is for cure because it hasn't been fully explained that treatment may not be for cure. It may be for prolonging, for improved survival. It might be for symptom control. There are many reasons why you might be having oncology treatment. So being very clear about what are the possible benefits from the treatment that you're receiving is going to be very important in your decision making. But we're often, as healthcare professionals, not very good at putting that information into useful sound in useful ways. we talk about control of cancer, but what does that really mean in terms of whether you will have improved quality of life, whether you will be able to do the things that you do? And it might be helpful if you think about your own goals, the things that you'd like to achieve, and actually say to your healthcare professionals, if I go through this treatment, am I likely to be able to achieve all of this? And what might be the compromises that I have to make? And the other question sometimes that's helpful to ask is, if I don't do the treatment, what happens? What does it look like? Quality of life is very different for everybody. It's also, to me, a very something very woolly that we don't think about actually that much until we're faced with illness. I'm very grateful to all the patients I've ever met and their families, because doing the work that I do really forces me to think about my quality of life much more than I would otherwise have done, and to think about what's important. So I'm sure that you have much more expertise than I do in this, because you've had to face these things. And all of these are so important in the decisions that you make around treatment. I have got a link here on this slide, and I hope that I can put it in the chat group or pass it on, because it's for a decision aid for metastatic breast cancer that's been developed through funding from cancer research. And what I like about it is that it was based on research work done talking to patients, mostly from University Malaya, but from other patients going through metastatic breast cancer. And so it puts some of these questions into the guide. It's also full of medical information as well, but it also gives us a structure for thinking through. It was launched on the 9th of October, so it's very new. And if nothing else, I would really welcome your feedback on it. I think that would be very, very helpful. I'm aware Ranjit, BCWA also has a decision aid. So again, I'd be very interested on your feedback for decision aids in general, because it's a trend in healthcare now to develop decision aids, and the more feedback we get, the better. So I've talked around difficult conversations around families and something about decision making. I leave you with just because I like elephants, I think they're useful in the conversations, and I really like this picture. I think it's quite pretty, and we all need some beautiful pictures in our lives sometimes. So thanks, Ranjit and Crystal, and over to you.
Thank you very much, Sylvia, because I love elephants too. I don't know why, but I just love them. Okay, so what we have is I have one question for you, Sylvia.
Mm-hmm.
I will show you the book that we have. Actually, it's not so much of a decision aid. It's actually a guidebook for patients made by survivors, from the survivor's perspective rather than the doctor's perspective, for mBC patients, for them to how to manage themselves during the different milestones and what key questions to ask doctors. My question to you is that from what I notice, medical training carries the tag of a cure or care model, which means that you either cure a patient
Yeah.
or you're a failure when you cannot cure the patient.
Yeah.
And that you hand over to others to care for the patient without any treatment, what they consider as hardcore medical treatment. So this is more of a medical model. To what extent do you think in Malaysia we are at the social model status? What is our social model status in the sense that I think if we look at diabetes, it has a social model status because people don't look at diabetes as something that's going to kill you. You can
Yeah.
continue to live, you know. It is
Yeah.
still there, it is still exists,
Mm.
but people can continue to live and prolong their lives. So we actually, I mean, to what extent do you think, and when do you think we will be able to achieve that social model uh, status where people can continue to live life for, you know, with or without medication, and not feel that that cure is the main item when
Yeah.
it comes to your illness?
Yeah. So, I think there has been a shift in healthcare. I'm optimistic about the younger generation of doctors coming through that there's far more understanding of cancer as another chronic disease, if you like diabetes, like as you say, and a better understanding of the impacts of illness, and I hope a move towards more patient-centered care. But I am aware, I think the healthcare system doesn't support that very well. And it's possibly around the targets that are set to achieve. I think there needs to be so much change in the healthcare system itself. It pushes, there's not enough time. And I do think we're not very good at working with patients and families to promote health. We tend to still talk, and again, this is language about the non-compliant, non-adherent, the person who refused. One of the things I hate is the patient claimed. And that introduces a dynamic that isn't helpful to the conversation. So I think the younger generation, it's a much more satisfactory way of working to be in partnership rather than telling people what to do and thinking you know best kind of thing. But I think in some ways the healthcare system doesn't quite support it. And I think also culturally, it's still a very hierarchical society. And we're too worried about upsetting each other. I'm very aware that patients don't tell us when we get it wrong, when we say the wrong things. They just smile and go away. So I would really encourage you sometimes to give good feedback as well, so that dynamic can change. Have I answered your question, Ranjit?
Yes, you have, very much, yeah, to the point. Crystal, if you could go higher a bit because you look very short next to. All right, great. Crystal, I have a
Okay.
question for you. I'll just move on to Crystal first. I wanted to know, you know, you before we started this session, we were talking among ourselves with Dr. Sylvia and also with you. You know, you did mention that you had like your first diagnosis, which was an early stage breast cancer, and then later when you were diagnosed with metastatic breast cancer, the situation changed for the people around you. And that would have affected not just the healthcare professionals, but your family, your friends, and everybody else. So my question to you is that, you know, how did you have the conversation, you know, with your family when you were diagnosed with metastatic breast cancer, how did you sort of get to that sort of discussion with them?
Yeah, I remember that time, and it's kind of very difficult to confirm that, through myself, to tell people I have a recurrence. So I actually seek the help from the doctors. So my oncologist, Dr. Prof. Maniza, she actually came to visit me at the ward together, where when the family members are around, to explain what is the meaning of recurrence, and to explain how would the treatment be carried out. And for the family members, Professor C volunteered to be the counselor for my children. So she's helping me to comfort them and let them ask her any question which they don't understand, and let them have a chance to voice out their opinions, their worries, and so on. Because that time my daughter just received a job and moving down to Singapore. So she was like, didn't know whether she should go or she should stay back. You see, so the counseling from the doctors to them, I think it was effective. With me alone, I cannot do all this alone. So I feel in future, if any one of us face this problem, we have to be daring enough to tell whoever you think can help you, to ask for help. Just ask for help. Don't keep everything in your heart. Just open up and ask for help. So so with the doctor's help, this news was able to be told to the family members, my husband and my children, and at least they have an idea on what is going to happen. Treatment is going to be a prolonged, and it's going to be continuous, and so on and so on. Yeah.
Yeah, you answered it very well, I must say. It actually resonates with what Dr. Sylvia mentioned earlier, that the impact of the illness itself, how it transcends down to the family and to the rest of the people. Dr. Sylvia, my question to you is that in an ideal situation, who should be talking to the patient and the family in a hospital setting?
So in a hospital setting, I think it's that's not where I work. So I want to be clear, I'm not an expert there. We have the advantage of going to people's homes, but I think it's very individual again. I certainly think the healthcare professionals should offer to take that role on, but from time to time, you'll find someone who wants to do it themselves. But I think as healthcare professionals, we need to be clear that we can set aside some time to talk to not just the patient, but the family as well, and to think in multidisciplinary terms, who else could come on board to help. It can't be fixed. It can't be the same for every person. I'm so glad to hear that Prof. Maniza spoke to your family. She's a lovely oncologist, I have to say.
Yes, yeah.
I'm coming back to the medical model issue. Dr. Sylvia, I wanted to ask you this question about the medical model. When a medical doctor speaks to the patient and the family, it's basically targeted towards treatment. Don't worry, we can get treatment for your family member, for the patient. Okay?
Yeah.
So when there comes a situation when there's a failure in the treatment fails the patient, what happens there in terms
Thank you,
of...
Ranjit. Thank you.
Because you as a doctor promised me
Yes.
that this treatment will work on me.
Yeah. So, you know, I think that those conversations suggest that we're having the wrong conversations at the outside. That I think the early conversations need around what's happening and where we're going with the treatment, and just saying nobody knows how this individual is going to respond to treatment, whether this is going to go well or not. And I think everybody embarking on treatment should know, as soon as you have an illness, not just cancer, life becomes a bit more uncertain and nobody knows exactly what's going to happen. And it's nobody's fault if things don't work out for the best. So I hope we never reach that end of the conversation around, oh, well, the treatment's failed, either because the doctor was useless or the patient was useless. It isn't. It just isn't like that. But I'm aware that that is sometimes how it's presented.
Yeah. I come back to Crystal about that, because I think in Crystal's situation, from conversations we've had with Crystal, she's very realistic about the whole situation, that she can openly say, if it fails me, it fails me, But in her case, she's talking about, trying her level best to ensure that she can live longer and a good quality of life at the same time, because I think quality of life makes a lot of difference, because patients make choices in relation to quality of life. From what I've seen, families make decisions not related to quality of life. They make decisions related to quantity of life.
Yes.
So I want both of you to explain that to us.
Crystal, you
want to go first?
Okay. I would say I'm quite lucky that I get cancer after age of 50, not like 40 years old when the children are still in secondary school, they're still young, we need to take care of them. So it's just when I have my recurrence, my daughter has started work. My son is still studying in a college. So that boils down to who to look after me. The first thing in my mind is who to look after me, because I was walking like a robot with a neck support, and I couldn't do a lot of things. Can't even prepare Maggie mee for myself. So we had a lot of family meetings and discussions, what is the best? Okay, the girl has to go to Singapore. Okay, you just go ahead. And then the boy at home, all right, can you take a semester off to look after mommy? And he went to the college and he applied this and applied that. And then college was very understanding and said, okay, no problem. All right, you come back next semester. So I have a full-time caregiver with me, look after me, my meals, and then everything. And my husband, as a marketing guy, he doesn't need to stay in the office from 9 to 5. He can communicate with the customer, with the office, through his computer system, through his handphone. So he is always in and out of the house. And simple small family makes the whole thing easy to be managed. And then I'm also the type who Ranjit will know I love food. So I will detect what I want to eat, for my next meal. And then they will go and search around for the food. Okay. So not too bad after all. not too bad after all. Yeah.
You managed well, I would say, Crystal, and I think that I would like to take you on as one of my counselors for MBC patients, because you'll be just brilliant. Before Dr. Sylvia replies, I have a message from from Chusan here, who is also an MBC patient, and she says, "Thanks, Dr. Sylvia, for an insightful information. Being an MBC patient for me is to communicate with my young kids and how to assure them that I can still live a normal life after treatment." Her children were at school, I think, at that time, to let them know, because Chusan is 7 years after being diagnosed with metastatic breast cancer.
Yeah.
And she also wanted to let them know the expensive cost of treatment. They can still continue their studies. If despite the expensive treatment, they could still continue their studies in private university or overseas. My eldest son was in private college then, and he accompanied me to my chemo treatment and also slept with me for the whole session. The nurse, I think she's talking about he slept during the chemo treatment during the whole session. And the nurse was impressed indeed, and my husband was stressed up with too many issues too. So it looked like the husband was more stressed than the children were. So over to you, Sylvia, to respond to the issue of quality of life and quantity of life, patient's choice, family's choice.
So I think what you've highlighted is very true. I'm always wary of generalizations, because obviously when we're talking with individuals, we have to understand that. But I do see the generalization that often it's the patient who is quite comfortable with what's going on and is focusing on quality of life. And the wonderful thing is how altruistic people are, and how frequently patients are far more concerned about their families than about themselves. And the families, of course, are far more concerned about the patient than themselves, but do tend to think more in terms of, we must do everything to ensure the longest time span possible, rather than focusing on how to manage what's going on now. So I think that, I suppose the generalizations, there's often a mismatch between what families are hoping for or focusing on and what patients are focusing on, and the conversations that bring us together are so important and actually often very enriching. I mean, from what Chusan's written, that the strength within her family there is huge, and might not have been recognized without what happened to Chusan. So that I think that sometimes we forget that there are positives around this.
We have another person who is Satya. She's one of our breast cancer survivors since 2008. She's a caregiver for someone with leukemia, a leukemia patient who was diagnosed in 2001, thymoma cancer patient since 1997, currently caregiver for someone with colorectal cancer, and also a caregiver for someone with lung cancer at one time. So, so she's been like, surrounded by this whole thing. Satya, are you able to speak today? Are you able to have yourself unmute today?
Yeah.
Because I know yes. Can we see you?
All right. Give me a minute. All right.
Yeah.
Okay. Can you see me? Yep.
Yes, we can see you. There you go.
Yeah.
So how do you cope, Satya?
Oh, you see, the timers was my sister, my late sister. That was a shocking thing for me. Totally shocking thing, because that time I was very, very young. I didn't understand. I didn't get any help from anyone. I was really running around for help, but God was there, and I found one doctor. Actually, he's a veterinarian doctor. He was very close to me, and he said, never mind, I will look for people for you to communicate with. And after that, he was really, really helping me to get to know this doctor, that doctor, and I was running around. At that time, financially was very down, and being a second girl in the family, and I was infected by my sister, my elder sister. right? So there was no help from other side rather than only my siblings. My siblings was young then. Just now Dr. Sylvia was saying that the family together and help and all that, that was where I got it. So we timetable those people who can help, and then we took turn. But initially it was difficult because the rest of them were younger to me, and only myself was able to communicate with doctors, and the doctors were very, very kind that time, and they helped me out. My elder sister-in-law, and then within 7 years, and then another shocking thing came in my life. Was my brother. My brother was a leukemia patient, and he was battling his life for a long time, and he had AML. Then the doctor said that chances of living is very rare, but we tried giving a lot of help and bone marrow transplant done for him. And it also there, God was very good with us because the donor was among us. One of my own brother gave the marrow transplant, and first time he survived for 2 years, and then it relapsed again, and then the second time it only lasts for 1 year, and the third time patient and doctor decided not to go through because my patient was like, he told me that, no, I don't want to die on the radiotherapy bed. I want to live with you guys. So he came and lived with me for 7 years. We were there, and only it's all solely my siblings were helping him. And last bit of it, he was with me all through. I was, I don't know, I was a mother for him, I think. I took care of him, and that's only painful thing that I went through with my brother. It was very hard for me because at the time I didn't understand. I think you all can see that was very much earlier, right? So very stressful, taking care of brother and looking after family. And my boys was grown up then, so they gave me a big help, being with the uncle, joking around. They know that he's going to die, but my children really gave a very good support, playing with him, taking him around, going with him, and he refused to go out the house. But my sons brought outdoor to indoor. They brought a lot of things, a lot of activities for him, and he was very happy. Actually, he died on my lap. And then, yeah, that's it. And then immediately a month later, then I was diagnosed with breast cancer. A month later, that's all. But I think these two people I was caring for, when I been diagnosed, I never cried at all. I said God was with me, and I go through. The rest of them were crying, but not me. Then I was going through the whole thing, coming out and all that. And then my children and my sibling was very good with me. They helped me a lot. They sacrificed their time for me. And then my husband fell sick with the colorectal cancer. That was a very challenging. I think, Ranjit, the other time I said, looking after other people better than looking at own spouse, right? So that was a very, very challenging. In fact, let me share it that I was crying daily because the colorectal, the stoma bag was with him, was there for him to look after for 6 months, and he refused to clean up himself. So I have to do it. I was working, and plus this, sometimes the bag just drops it because when I fix it, he really is very clumsy and he drops. He will stand until I come home to clean up. It was a really challenging time for me, but God pulled me through everything, and yeah, I am going well. And I think God saw that I was crying for 6 months. I think he decided reverse back. His stoma was reverse back, so I was so happy about it. And yeah, it's still going on. He's still going on. So in between, that is the time I've decided to go and help people, the lung cancer people. And I told myself, no, these are the things I have experience going through patients. So I'll go and help people around. I'm in Negeri Sembilan, right? So whoever called me, whoever says anything, I'm there for them. I'm there, before COVID, I used to visit them in their house. Now only telecommunication, but I hope everything is fine now. I also lost 2 of them in lung cancer. There was a terminal lung cancer, and one with a stomach cancer. Also, I lost them, and I've lost my brother and my sister. My husband is still a survivor; is still living. That's my old story about Ranjit.
You've done great.
Yeah, thank you, Ranjit. Thank you.
Sylvia, over to you.
Satya, thank you so much for sharing that, because I just can't imagine what you've been through. That's extraordinary, and I just wondered if you have any kind of general things that helped you through coping strategies, if you like.
I don't know. I still feel I've not learned much. I don't know. I still feel that way. Yeah.
It's difficult to assess
Yeah.
yourself, but others could assess you very easily.
It is. Yeah. And I think, again, actually, you added weight to this sort of sense of it's very different being a patient to being a carer. And I don't want to dismiss it, but almost easier to be the patient than the carer sometimes. I'm very wary of saying that, because it's never easy either side, but it's different.
Satya?
Yeah, it is really, really different. And when I was young, I was looking after my sister. Yeah, it was a very painful thing, and there's no help, and it was very painful. Mm-hmm. And keeping my brother with me, and of course, bringing our family into that family member, and then spouses are not happy. My spouse was not happy at all to keep my brother in my house. And my brother wanted to be with me alone, It was a battle for me.
Yeah.
But God is good. He's been doing everything for me from the right. Many times I thought I can, you know what I mean? Yeah, not because of my sickness, because my husband's colorectal thing, that was very, very tough for me. Very, very tough. In fact, the doctor was telling him, you have to clean up your own. You can't be doing this to your wife because she's also a cancer patient, But, well, I don't understand why he didn't do it. Till that 6 months. It was a very hard time for me. But I think I've learned that. I think God made me to go through, to mold me, to accept other people. I think, I'm not sure. I don't know, Dr. Sylvia. I don't know what I want to do. I'm really like lost. I don't know. Maybe Ms. Ranjit can do something or teach me something. I don't know. Yeah.
Thank you.
Yeah.
Thanks for sharing, Satya. I think you did mention a number of times, and I think your faith keeps you going as well in life. Yeah. Dr. Sylvia, I think there's you're talking to people who are very open about this whole issue.
Yes.
What are the issues that you notice in terms of conspiracy of silence, where people don't talk about it, or they don't mention the word cancer, and everybody silently, sometimes the patient may know, but they don't talk openly about it. What about those type of scenarios where difficult conversations are something of a barrier to many things? Whereas if it is considered as an acceptance of something that is given a different name, it's fine. But when it's not, and there's a bit of an awkwardness in those difficult conversations, how do you go around it then?
So I think obviously within this group, everybody is very open. usually the reluctance to talk, or the fear around talking, or the fear around sometimes, families not wanting to tell the patient themselves what that they have cancer, is a fear of hurting each other, and so often those conspiracies of silence cause much more pain than openness. And so as healthcare professionals, we would always encourage more openness, while at the same time respecting that everybody is working to the best intention.
Right.
So we would just always explore the person's, their own kind of thinking, what they're worried about in being more open, what they fear, and hope to be able to give some context around that will make it easier. With patients, we will never directly say, oh, you've got cancer and this is a bad situation or whatever. We will always ask. We'll ask what they understand about their situation, what they know about their situation. We'll ask them how much they want to know about their situation, how much they want other people involved. And there are patients who don't want to know, who don't want to talk about it. And we'll again explore what are their fears around talking about it. But ultimately, that's another coping mechanism. And if they are coping, then we would need to respect that, but also be aware that that might change. So, and with families, we would hope that we can bring the conversation to a point where there is more openness, particularly when it comes to making decisions around treatment, because everyone says we want the best, but in order to understand what the best is, we do have to talk about the cancer, we do have to talk about the future, the outcomes. And sometimes if you put that there, if you say, well, I know you want the best, but we need to all talk about this because the best is about quality of life. And so we all need to talk about what that means. And we need to be able to talk about what's going on.
Right.
The best isn't a purely medical decision. This is the best chemotherapy.
Many a time, so Dr. Sylvia, we have this situation where the mother may be very, very old. All right. She may be in her 90s, and the daughter decides that she's not going to tell her because she doesn't want to bother her much.
Yeah. Yeah.
I would like to bring Chu San into the picture here. Chu San, would you like to come on? Chu San is a metastatic breast cancer patient for 7 years. And Chu San had made a very conscious decision because her mother was staying in Sarawak and Chu San was here in KL. So she decided that she will not tell her mother, who was in her 90s, because she wanted to spare her all that, whole thing of when elderly people think of the word cancer, it can be very frightening for them. Compared to our age group. Chu San, do you want to come on, Chu San?
Hello, but I can't on the video. I don't
Okay, no worries. We can hear you.
All right. Hi, good morning. Because during my 7 years ago, my mother then was in Sarawak. It was about. So she didn't know until she passed on. I got a metastasis. Because after my treatment for 2 years, I didn't go back to Sarawak. I didn't want her to see I got my hairs were bald. So I just tell her I'm well. I still communicate through phone only. I didn't go back home. But when I started to have hair, then I went back. I just told her that, I'm well. But I was well after my treatment. So not so much of problem. The only problem actually is more on my mother-in-law. She is the one who is more worried, and she is like getting worrier, and she even felt unwell when she heard that I had cancer and I had metastatic breast cancer. She wanted to come to my house and take care of me actually, but my in-law said she is not too well to take care of me. Instead, she will give me more stress instead of staying with me. So that is the story of my mBC. Yeah. Only my mom lah, but my sister, they all came.
Yeah. Thank you, Chusan. I think again very individual as to who and how we tell things within the family. And certainly for the older generation, their whole experience of cancer has been very different to our experience of cancer. Cancer very much meant a death sentence before, and it's changed. And so yes, how much you tell your elderly relative depends on the individual, how much they know. I do think with older people, sometimes we need to be wary, not so much as telling them that someone's got cancer, but when they have cancer themselves, they do know what's going on. We sometimes think they don't know what's going on, but they do know what's going on, but they've chosen not to trouble you as well. So sometimes that can be the situation. And I've had very pragmatic older people who tell me, well, there's no point talking, it is what it is. So again, everyone's different, but whatever age you are, to have a child, and I say child, they may be adult children going through illness, is so out of the order of things. I think it's so hard. So yes, you might want to spare your elderly parents from knowing what you're going through. I totally see that.
So it's the dynamics of the relationship, from what I can see, that as a parent, you don't want your child to suffer, whatever the age of your child.
Absolutely.
So as a child, you want to spare your parent from that suffering. So I think that's the dynamics of that relationship of protection. Your parents protect you, and they don't want you to go into any harm. You know, Chusan, coming to you, I was wondering, did you leave anybody out, and what was the reason for not telling them? Sorry, Crystal. Yeah, sorry, Chusan, you've already talked about your mom. I wanted to know from Crystal. Crystal, was there anyone that you felt you shouldn't be telling because you want to protect them from this whole suffering?
I didn't hide from my mother or my mother-in-law, but my mother at the time, I think she has started to have dementia and not able to understand well what I was talking. My mother-in-law, who stays in Penang, didn't get to see me so often. She was quite worried. But we kept on telling her, oh, okay, we know the doctors very well. You know, we have insurance coverage. Don't worry about us. You know, we try to comfort her, you know. And then I still go back. I remember during the recurrence, the doctor, another doctor, I moved from University of Malaya Hospital to a private hospital because I'm on targeted drugs and the cost is the same. So why not I go to the private end? So that doctor was so eager. Immediately he wanted to do a chemo on me. And that was just a few days before Chinese New Year. He said, it's urgent, have to do. It's already 3 months, you're not doing anything. Okay. So only that year, I didn't go back to Penang for Chinese New Year. Other than that, I was okay. Yeah. So basically, everyone in the family was informed, together with all the sisters and brothers, on what is going on now. Because I feel by saying things out, will have less worries on the other person, the other end, rather than if I don't tell them anything, then they will start guessing.
Yeah.
I think a lot of people make this mistake, they thought by not saying the word out or by not bringing up the issue means I will look peaceful. But actually, I don't think it's correct. I don't think it's correct. It will make the others start guessing on all possibilities, which it won't bring any benefits.
So this is what
my opinion.
Yeah, this is what you view. I mean, other people view you as, right? If you dress up well and you go out, and people will say, "Wow, she's so brave." Dr. Sylvia had touched on that point, that the person is being very brave. Whereas we think that we are just being normal, being ourselves. I mean, Dr. Sylvia, what do you think of that? I mean, is there going to be a change in this whole scenario? Do you see some optimism in the future when how people are going to view cancer and the impact of cancer on people's lives?
I think there's always change. I think the more patients and carers are involved in the conversation, the more it can be moved in a direction that is more helpful. But society works by creating labels around people. We often want to fit people into pigeonholes, whether it's about illness or about anything else. And however you decide to handle your illness, it will never be the right way for everybody, I think, sadly. And I think that's some of the dilemma of to tell or not to tell, because it will change people's perception of you. At the same time, if you, as Crystal pointed out, if you don't tell, they'll be guessing. They will. Yeah, you can't win. Sorry.
Yeah. So I think what Crystal and Chusan or anyone else who's like Satya are doing, isn't it a form of education for the public, for the healthcare professionals, for other patients and caregivers?
Absolutely, and that's why, what I'm saying is for you guys all to speak out, to tell healthcare professionals on an individual level how you want to be spoken to, what works for you, what doesn't. The more they hear that, the more feedback they get, the better. But also in public forums and in public spaces to talk about it. Because then you're in charge of the conversation. Don't leave it to us, guys. We're useless.
And they'll know more. They will not have this hand on the mouth saying she has cancer.
Yeah. I do think that the whole stigma around cancer, and tell me if I'm wrong, is a bit less now. But certainly the older generation do feel like you've done something wrong if you get cancer. But I think that is less of an issue. I really hope it's less of an issue.
You did mention a little bit about going virtual and stuff like that, and I was just thinking, besides virtual, if you have the internet, I know that nowadays school-going children will just go on the internet and learn about the disease and come back and tell their mother, look, I have read about this and I know what it is all about. So do you think that that kind of education is going to create a society that is better informed, create a society that will be less judgmental, less labeling, less stigmatizing in terms of the word cancer?
So I'm not a social media expert by any means, but it definitely has a role to play. And I would encourage you to put your voices out there. The sort of note of caution is there are a lot of voices out there saying different things, and how do you filter the information you're getting? How do you know whether this is reliable information or not? But the voices of people who are experiencing things are so important. The more that they're out there, the more that we can see the range is so important. And you've got to go to Instagram and TikTok, I'm afraid. I can just about do Instagram. I really can't do TikTok. Have you thought about a TikTok video, Ranjit?
Pardon?
TikTok video?
No. I have no time for those things.
If we're going to get to the younger generation, that's what
Yes,
we've got
yes,
to do,
yes.
I'm afraid.
Yeah, that's true. But the younger generation is not listening to us, they're listening to somebody else. So we let others educate them as well, because I think education is important. It may not be,
Yeah.
it may not be formal education, but it is like social education that
Yes.
and will tip the balance and create that
Yeah.
critical mass, which will eventually bring the balance about
Yeah.
for people to be better informed. And
Yeah.
Chusan says, I have encountered a doctor who asked me to go back and do whatever I can, go for spiritual help. I don't quite like it that way. Dr. Sylvia, what is your opinion? Because the doctor actually, this was one of the top oncologists in the country, in the government, who actually said to Chusan, go home and pray because you don't have much time left. She's
Ooh.
still alive 7 years later. She might outlive him. So she's asked for your opinion about this.
I think unfortunately, it's quite an abandoning statement. It's over to you. It's now your problem. And now, certainly for oncology, that there is a time when it's no longer helpful. But I think there's another way of saying that, there are other options. There are always other options. And there are other healthcare professionals in other fields that can help you with the things that you're facing. I'm not the right person at the moment, might be the way to do it. But no, a statement like that is very abandoning, and I think not helpful.
Yeah, Dr. Sylvia, because when I was, I got the appointment with this oncologist, top oncologist some more. I was so happy. I was very happy, and I said I was so lucky to get him. But after that statement, I was really down.
Yeah.
Yeah, that's why I was thinking, what are the steps next? Took at least 1 or 2 days to digest it and to move on. Yeah.
I think that's very hard for you, Chusan, and there's a lot of literature around communication for oncologists. A lot of work has been done, but there still needs to be more work in the medical education around how do you communicate, particularly through transitions of care. So when you're moving from a focus on cure to a focus on prolonging or surviving, those conversations are difficult, and that there are ways of having those conversations better. Usually you just need to ask a bit more and say less or give less advice, I think. Can't hear you, Ranjit, sorry.
There are certain doctors who've started saying, I don't know more about this. Maybe I could refer you to somebody else who can help you better than I can, And I think that creates an avenue, a door is open for us as patients to go and seek more help from other sectors or other areas as well. And I think that those kind of conversations are very important, because when the patient gets this kind of communication from the doctor, the patient is going to have to decide, what am I going to tell my family about, what happened, what transpired, because you're not going to keep it to yourself. You have to go back and tell your family, should I divulge to them, this is what the doctor said, or should I keep quiet because I want to protect them? I don't want them to get hurt either, So there's so many things. It's a very complex situation. It's not as simple as that. It is very easy for the for a healthcare provider to actually have a mask and just say it. But what happens, like you say, the impact of the information and the way the information is given,
it's huge.
How it affects the patient and the family. And that conversation is really a very important touch point in our lives when we are told about this condition and what can be done about it. And that's why we have the Crystals and the Chusans and the Satyas and so many of these people who are out there to educate people. And I do think that if I had my way, I'll put them as lecturers in medical universities.
Yes.
Yeah, really, to talk about what they thought was a good conversation with the healthcare provider, what they thought was not a very good conversation with the healthcare provider, and how that could be changed, you know. And I think that will create a better understanding of this patient is not just this patient. There's a unit, there's a family, there are other people who are infected by it as well. So I think I would like to now give an opportunity to both our guest speakers. Maybe I can start with Chusan first. After that, I'll come to Crystal and to Sylvia to conclude the session. So Chusan, would you like to say a few words before we conclude?
Yeah, for me, I think conversation and communication is of course very important. For me, I think my most worried is my kids lah, because I really I love them so much. So some of the things they can see lah from what my way of life, you know, I live a quality life, so they are now quite happy lah with how their mommy is living, and they feel more secure and safe. Yeah. Other than that, I think myself and my husband, we are very open. Yeah, we talk about anything, everything. So actually, he's more stressed than me. So I have to assure them that I'm okay. I live my life. I don't want to burden them so much. Thanks, doctor. Thanks, Ranjit. Thanks, Crystal.
You're welcome, Chusan. We'll have a group photo afterwards. Crystal, over to you.
Yeah, I feel to be honest to everyone around me, because some patients, they may think, you know, I don't want to tell the children about this, but, and then try to act like I'm okay, I can accept it, you know, I'm doing it well, try to be strong in front of the family member, for example, which I don't think is necessary. It will add stress to ourselves, and they will make the disease progress faster. So just be yourself. Like me, I just be myself. If I need to be angry, I will be angry. If I need to scold my husband, I just scold him lah. What to do?
Okay, Dr. Sylvia, what about you? Concluding remarks from you.
Right. Thank you very much. I've really enjoyed this conversation, and I hope what I've said has been in some way helpful. I would say to those of you with metastatic disease, we've talked a lot about quality of life. And one of the things that helps when you're going through this kind of disease and illness with treatment, it's very difficult. So if you are struggling, please do ask for a referral to palliative care. This doesn't mean you're at the end at all. It just means that there are huge impacts and you need support, and that's what palliative care is there for. It's to help with symptoms, it's to help with difficult conversations, it's to help emotionally alongside the treatment you're undergoing. So please don't wait for your oncologists to suggest, because they tend to refer much too late, and you might be missing out on some benefits, potential benefits. Once, like Chusan, you're better and well and stable, don't need palliative care, discharge from palliative care. So I'm just putting a little advert there, that there are other avenues of support that sometimes get overlooked, again, because of this fear of giving a negative message.
Thank you, Dr. Sylvia. What we have is, for Dr. Sylvia's information and everyone else, we have a group called Pink Inspirers. And this is a group of women with metastatic breast cancer. Chusan, Crystal, and quite a number of them are in the group. It's a WhatsApp group, and they communicate with one another. We have also had sessions to sensitize them to palliative care. Professor Tan Seng Beng has been the one who's been giving talks to them, and also has been able to explain to them the continuum of where you actually need both the medical medical care and palliative care hand in hand together.
Yeah.
And and when is the time when you don't need one of them at all and just the
Yeah.
other one, and when you need both together. And he thinks, I mean, he has also explained to them, you don't need to wait until it's so late to go
Yeah.
into palliative care. So both need to, and I do believe very much in the fact that palliative care, actually, if it is brought in right at the very beginning, it would have been very helpful for us, to particularly with regards to our side effects.
Yes.
It would have helped a great deal, but it has not really been introduced to us. And I've told Professor Tan Seng Beng, we need many, many more people like you guys, even in primary health care. If we have palliative care, palliative care division, which can actually be the one that handle the patients in terms of side effects, because don't wait until the side effects take place, but in advance, you can tell them, if this happens, this is what you do. When is the time you need to go to emergency? When is the time you might just go and see a GP and say, I have this problem, and get it sorted out. So we do stress a lot on palliative care, and we try and sensitize people that palliative care is not end of life. It is actually part of life. Thank you to our speakers. Thank you to our listeners. Thank you, everyone. Let's give a big hand to Dr. Sylvia. And thank you very much also to Crystal, a big hand to Crystal. And thank you to all those who shared their experience, Satya and Chusan and everyone else who listened today. Have a good day, have a good weekend.